ठीक है, इस अरेंजमेंट का फायदा क्या है कि just below the skin and lying superficial to the extensor expansion of dorsum of hand. इसका फायदा क्या है? जी, आप में से कोई एक?
थर्मोरेगुलेशन में।
थर्मोरेगुलेशन, ठीक है, और इसके अलावा? The superficial palmar arch or dorsal venous arch lies, the dorsal venous arch on the dorsum of the hand lies superficial to the extensor expansion and just below the skin. One of the benefits to this is thermoregulation. Any other benefit?
Intravenous injection.
Intravenous injection can be. Any other? You know that the veins do not have valves and they are thin walled structures. So, in case they are present under the extensor expansion or the muscles, so in case of the contraction of these muscles, that would lead to the blockade to the venous return. So when these are present superficial to the extensor expansion, even in the condition of flexed hand or the flexed fingers, the venous blood will not be hindered to flow back to the systemic circulation. So the benefit of the dorsal venous arch present superficial to the extensor expansion is one, thermoregulation, can be used for the intravenous administrations or injections, and most importantly, they are not affected by the positions of the hand or contraction, so that the venous return continues properly and is not blocked. So from the dorsal venous arch, there are two ends, the lateral end towards the thumb and the medial end towards the little finger. If we talk about the lateral aspect first, okay, so from the lateral aspect, it continues upward as the cephalic vein. Cephalic is the term used towards the head, and basalic will be from the medial side, that would be the base or medial side. So after origination from the dorsum of hand, they shift to the lateral aspect of the forearm and later on anterior aspect. These veins shift towards the anterior aspect of the forearm. Then what would happen? If we are talking about the cephalic vein, it would run vertically upwards on the lateral side of the forearm. In the region of cubital fossa or elbow joint, it gives a communicating channel that would run medially and upwards and would join. जी
सर, ये डोर्सल वीनस आर्च तो डोर्सली प्रेजेंट है, जबकि क्यूबिटल फोसा वेंट्रली प्रेजेंट होता है टू द फोरआर्म.
Yes.
तो ये सर क्या ये टिल्ट होकर आता है?
That I have just told that the dorsal venous arch is present on the dorsum of the hand. From its lateral and medial aspects, the two collective veins or the single veins which start are the basalic vein and the cephalic vein. In the region of wrist and distal forearm, that
सर आपकी आवाज कट गई है.
इसके रीजन में आके वो lateral हो जाएंगी, wrist or lateral distal 1/3 of the forearm, and then when it moves upward, so when it moves upward, it continues on the interior aspect of the forearm. So that is the reason that the median cubital vein, and these are present or visualized from the anterior aspect. Okay, so the cephalic vein, while ascending up, gives a communicating branch anterior to the cubital fossa or elbow joint that runs medially and will meet. The cephalic vein then continues itself again just a minute. Groove, it passes the clavipectoral fascia and would drain into the axillary vein. To revise, the cephalic vein starts from the lateral aspect of the dorsal venous arch, ascends upward along the lateral side of the forearm. In the region of cubital fossa or elbow joint, it gives a communicating branch, that is median cubital vein. Then again it ascends on the lateral aspect, moving along the contour of the deltoid muscle. And in the deltopectoral groove, that is the depression or the gap between the pectoralis major and the deltoid muscle, it passes the clavipectoral fascia and would drain into the axillary vein. And while we are talking about the medial aspect, so from the medial end of the dorsal venous arch, there is a continuation is named as the basalic vein, that is from the base. Okay, it ascends along the medial side of the forearm, gets a communication, that is the median cubital vein, and again it ascends upward. The typical importance or difference between these two, the lumen of the cephalic vein continues to be the same. The diameter or the lumen of the cephalic vein continues as such throughout the course, whereas as the basalic vein moves upward, its diameter increases. And in middle of the arm, the basalic vein combines with the vena committantes of the brachial artery at the lower border of teres major to form the which vein?
Axillary vein.
Axillary vein.
Okay, so if we are talking about the formation of axillary vein, that is by basalic vein along with the vena committantes of brachial artery. And if we are talking about the tributaries of axillary vein, so that would be the cephalic vein. Clear so far? And then
फोरआर्म के लेवल पर हम बेसिलिक वेन को डिफरेंशिएट कर सकते हैं, वहां पे तो परफोरेटिंग वेन्स भी बहुत ज्यादा होती हैं.
जी बिल्कुल, it can be identified as a separate vein because it is larger in lumen as compared to the perforating veins. So just because आप इंशाल्लाह on campus you will be seeing the prosected bodies, you will be able to identify both these veins, cephalic as well as the basalic vein.
सर मैंने एक जगह पे पढ़ा था, एक वीडियो में सुना था, वो कह रहा था कि जो आपके पास मीडियन एंटीब्रैकियल वेन है ना, उससे मेनली बेसिलिक वेन जो है वो ओरिजिनेट करती है और हम इसे आइडेंटिफाई करते हैं क्यूबिटल फोसा के बाद अब सुपीरियर साइड पे आर्म के लेवल पर. तो फोर आर्म के लेवल पर इसे डिफरेंशिएट करना काफी मुश्किल होता है परफोरेटिंग वेन की वजह से.
मुश्किल होता है पर इम्पॉसिबल नहीं है. ठीक है, व्हेन यू डिसेक्टेड योरसेल्फ द कैडेवर, ठीक है, तो उसमें आप ये चीजें आइडेंटिफाई साथ साथ करते जाते हो और ये कंटिन्यूस होती हैं. सो वो एक ही वेन जो कंटिन्यूस होगी आर्म से लेके हैंड तक, सो दैट वुड बी द बेसिलिक वेन.
सर वेना कॉमिटेंटस आपने कहा था, वो क्या होता है?
These are the small veins which run along the wall of the main artery. कि ब्रेकियल आर्टरी थी, उसके साथ छोटी वेन्स जो जा रही हैं, जो उसके साथ जुड़ी हुई हैं, they are the vena comitatus.
सर ये डीप के साथ ही सिर्फ होंगी?
जी डीप के साथ होंगी, क्योंकि सुपरफिशियल खुद छोटी ब्रांचेस हैं, उनके साथ वेन्स की जरूरत नहीं है. अच्छा जी, if we talk about the lymphatic, जी
सर वीनस ड्रेनेज की बात करते हुए हम पामर वीनस ड्रेनेज को क्यों छोड़ देते हैं, सिर्फ डोर्सल की बात की है?
The reason being they are this very minute veins which are present in the palm region, and they are communicating both on the palmar aspect as well as the dorsal aspect. So they are not very well marked or well differentiated that could be identified grossly. So that is
सर
why, जी,
सर ये जो सुपरफिशियल पामर वीनस आर्च है, इसी से हमारे पास मीडियन एंटीब्रैकियल वेन जो कि सुपरफिशियल वेन है वो ओरिजिनेट करती है, और इसी
जी।
से डीप वेन जो अल्नर नर्व है, अल्नर वेन है, वो भी ओरिजिनेट करती है। तो ये मैंने पढ़ा था, ये सही है सर कि अल्नर वेन भी इसी से ओरिजिनेट करती है और मीडियन एंटीब्रैकियल वेन भी इसी से ओरिजिनेट करती है, सुपरफिशियल पामर वीनस आर्च।
अच्छा, जो अल्नर वेन की आप बात कर रहे हो दैट वुड बी अ डीप वेन, ठीक है।
यस सर।
जब हम सुपरफिशियल की बात करेंगे फिर अल्नर वेन का जिक्र नहीं आएगा।
लेकिन सर ओरिजिनेट इसी से होती है।
देखो बात ये है कि हैंड देयर आर वेरी न्यूमरस माइन्यूट वेन्स प्रेजेंट इन द हैंड, so we cannot be very sure कि from which vessels combination this ulnar vein or the radial vein would start.
Thank you sir.
And this vein is not very well marked or well identified. If we talk about the superficial lymphatics, again we would divide the upper limb into lateral half and the medial half. So it is as similar as that of the superficial venous drainage. From the lateral half of the upper limb, the lymphatic vessels ascend up along the lateral side, okay, and they up till they reach in the shoulder region to the supraclavicular group of lymph nodes, and from here this lymph would drain in passing through the clavipectoral fascia, again would drain into the systemic veins, okay, or deep clavicular lymph nodes. Along the medial side there is a small difference. Okay, if you say the lymphatic drainage from the medial aspect ascends up, some of the lymphatic vessels would first relay in small group of lymph nodes present above the cubital fossa. So that would be supratrochlear lymph nodes. Some lymphatics of the medial half of the upper limb would first relay in the supratrochlear group of lymph nodes, and after filtration from these, the lymph would again move upward, and the rest of the lymph is going directly. 5 to 10% relay in the supratrochlear group of lymph nodes, rest ascend unrelayed, and in the upper arm they all drain into the lateral group of axillary lymph nodes, and from the lateral group of axillary lymph nodes they would move to the apical group of axillary lymph nodes.
सर
Do you?
सर हमने एफएससी में एक बात पढ़ी थी कि सेवरल एफरेंट वेसल्स वो ड्रेन करती हैं इन सिंगल लिम्फ नोड, जबकि लिम्फ नोड से सिर्फ एक ही वेसल निकलती है, इफरेंट वेसल। जबकि हम डायग्राम में देखते हैं तो इफरेंट और एफरेंट काफी सारी निकल रही हैं एक ही लिम्फ नोड से। एफएससी वाली में हमने पढ़ा था कि काफी सारी आएंगी लेकिन जाएगी सिर्फ एक ही।
अब उसमें थोड़ा सा फर्क ये है कि द डिफरेंस इन द कॉन्सेप्ट इज कि from the lymph node there would be the single vessel that is going back, but from the surrounding regions, surrounding area, there would be multiple new afferent vessels that are beginning, and that would ascend along with the main lymphatic vessel from the lymph node. So when we see a complete picture, so that gives an impression that there are numerous ones, but if we are concerned with a single lymph node, it would give a single lymph vessel. And in the surrounding area, there would be the multiple new vessels, afferent vessels that are beginning, that combinedly give an impression of more afferent lymphatic vessels. Regarding the clinical anatomy of elbow joint, the most common clinical condition is the pulled elbow that is most commonly seen in the children. What happens is when the younger age children are pulled up or lifted with the by holding their hands, as the annular ligament is not very well developed, and in addition the ossification of bone is going on, so the head and the neck region of radius is not fully developed, that is smaller in size as compared to the adult structure or adult position, so that can easily be slipped out of the annular ligament, and that is called the word elbow. Then you would have read the regarding the superior and inferior radioulnar joints, the movement which are occurring, which movements occur at the superior and inferior radioulnar joints?
Supination and pronation.
Supination
and supination.
Pronation and supination. These are the movements which are rotatory in nature. ठीक है, so उससे अब आगे जो important चीज याद रखनी है, the thing that should be recalled and remembered, that these movements are not at the elbow joint or wrist joint. The muscles which are involved in the supination are, which muscles supinate the
Supinator and biceps brachii.
More powerful would be the biceps brachii, and the supinator would be assisting it. And for pronation, there are two muscles mainly, which are pronator quadratus, pronator teres.
Pronator teres.
Just a minute, ये आपको ये एटलस शो हो रहा?
Yes, sir.
Okay.
सर इसको डाउनलोड करने का तरीका क्या है?
This is a licensed version, so I cannot be able to tell that.
Okay, sir.
For supination, the muscles involved are the biceps brachii and supinator, and to some extent it is supported by the brachioradialis muscle. So if the forearm is in the mid-prone position, then biceps brachii would be the powerful action of supination, and otherwise the supinator muscle that is in the deep layer of extensor compartment of forearm, that would be involved. And for pronation, the muscles that are involved are
pronator teres and pronator quadratus.
pronator teres and pronator quadratus. ठीक है. These are the muscles which are acting. This is a supine position. The pronator teres is acting on the shaft of the radius, and the pronator quadratus is acting at the lower end of both bones. So these collectively produce the movement of pronation. Then is the wrist extension and wrist extension and flexion.
सर यहीं पे थोड़ा मिड रेडियोलर जॉइंट का तो बता दें, सुपीरियर इंफीरियर का तो पता चल गया, मिड का बता दें.
Just a minute, I'll be telling that as well. अच्छा जी, अगर wrist की extension की हम बात करते हैं, we are talking about the extension of the wrist. So main extensor would be extensor digitorum, and in addition extensor digiti minimi and extensor indicis. These are mainly the extensors of the wrist joint. ठीक है, और flexors कौन से होंगे? What would be the flexors of
Flexor
wrist joint?
Officialis, flexor digitorum profundus, and flexor pollicis longus.
Flexor carpi ulnaris, flexor carpi radialis. ठीक है, all these would be involved in the flexion of wrist joint. Then the two other movements which are occurring at the wrist joint are adduction and abduction.
सर केएलएम में सर्कमडक्शन पे लिखा है.
Just a minute, I am going to that. First, let me clear these four movements first. The outward movement is the abduction and the medial movement would be the adduction. Okay, and you can see that adduction is more in range as compared to the abduction because the styloid process of radius and ulna are not at the same level that limit the abduction and allow more range of movement in the adduction movement. Now that question is circumduction. Which movement is called circumduction?
The union or the summation of flexion, extension, abduction, adduction is circumduction.
Anyone else?
360 degrees movement.
A circular movement is called the circumduction and a circumference. ठीक, so यहाँ पे थोड़ा the difference in the concept is ठीक है कि when you perform individual movements of flexion, extension, adduction and abduction, they are in four different directions or two planes. Oblique movement which help in this circular action is missing. Okay, so for that there are mid-carpal joints and intercarpal joints, which are the smaller joints of the carpal bones. They assist the rest of the wrist joint in a circular movement which appears to be. So when we are talking about the wrist joint alone, circumduction is not independently occurring at this joint, but wrist joint along with the mid-carpal and intercarpal joint collectively will cause the circumduction. So ये अपने point clear रखना है कि when we are talking about the circumduction at wrist, so the additional joints which are involved would be the intercarpal and mid-carpal joint. The mid-carpal joints are between the proximal and the distal row. Then there was a question of mid-radioulnar joint. The superior radioulnar joint is the bony one. Inferior radioulnar joint is again the bony one. In between the shaft of the two bones, there is interosseous membrane, which helps in the transmission of forces from one bone to the other or transmission of weight from one bone to the other. ये वाला ठीक है. This interosseous membrane is connecting the interosseous border of radius and ulna. तो इससे क्या होगा कि when और आपने you have read that in the formation of wrist joint only the radius is involved and not the ulna, and for the elbow joint the main articulation is between the humerus and ulna. So there must be some mechanism of weight transmission or force transmission from hand to the humerus, because these bones are not directly transmitting weight to one another. So this interosseous membrane is acting as the mid-radioulnar joint and helps in the transmission of force from the radius to ulna. So इसी तरह आपने जब radius से ulna पढ़ी थी तो that homologous to the leg bones जब किया था तो the radius is the lateral bone of upper limb and it is homologous to the tibia of the lower limb, which is the medial bone. And similarly, the ulna, which is the medial bone of the upper forearm, is homologous to the fibula of the leg, which is the lateral one. इसकी वजह जो इनकी positional change की थी, that was the embryological rotation. Upper limb rotates 90 degree lateral during embryonic life and the lower limbs rotate 90 degree medial during development.
सर इसकी
That
समझ
gives-
नहीं आती. सही समझ नहीं
किस
आती.
बात की?
सर इसी
Rotation की?
वाली.
Rotation of limbs की?
Yes sir.
Okay. In the embryonic life, both upper and lower limbs are in the anterior plane. Upper limbs rotate 90 degree lateral so that the thumbs becomes lateral, the palmar surface becomes interior, dorsum becomes posterior, and similarly, the medial muscles which were flexors become anterior, and the lateral muscles which were extensors become posterior. Clear so far? Initially, limbs are in straight direction. The medial muscles are flexors and the lateral ones are extensors. Upper limb rotate 90-degree lateral to attain their adult position, whereas for lower limbs they rotate 90-degree medial. So that would lead to the toes, big toes medially, dorsum of the foot above and the plantar surface below. Similarly, the medial muscles which were the flexors become posterior and the lateral muscles which were extensors become anterior. So this is the difference in the rotation direction of upper and lower limbs that causes these changes.
Thank you, sir. Clear.
उसके बाद hand opposition movement अब देखने के लिए opposition of the thumb and the little finger is like this. And thumb moves medially towards the little finger. Okay, so now moving back to our main presentation. Folded elbow, we have talked about the folded elbow. What you see in these images. Now we will be moving quickly so that we can cover complete the important clinical aspects. What abnormality you see in both the palms?
Red white sign is Jubitant contracture.
Jubitant contraction, what is it?
It is thickening of Palmer Apinerosis that is because of the proliferative fibroplasia of the digital and the Palmer aspect that results in the thickening of Palmer Apinerosis.
Okay. This is the Palmer Apinerosis, which is a triangular sheet connected proximally to the flexor retinaculum, and distally it is attached or spreads out in the four tendons for 4 digits. So this is a thick sheet of connective tissue or deep fascia. There is a very less healing ability in the connective tissue sheets. So in case of any lesion, if it is cut through, कोई इसका tear हो जाए, so that would not be completely healing, and the cut end margins would overlap one another. So what would be the result of this overhead healing, overlapping healing? Normally when there was a length of, for example, 8 centimeter, but when the two cut edges come together to fuse and heal, so the length would remain about 6 centimeter. So in that area, the flexibility or the movement range would decrease and the skin fold would be visible. And this contracture or the contraction during healing is called the Dupuytren contracture, that is specifically associated with the Palmer Apinerosis. Here, after the cut or tear of the Palmer Apinerosis, when healing occurs, that leads to the development of shortening of that area, and grossly it appears like these contractures called the Dupuytren contractures. Very good. Uske baad, when we are talking about the short muscles of hand, the important concept to remember is, if someone asks you name the muscles of the thenar eminence, what would they be? How many and what name? Which one would be?
Sir,
3 muscles हैं.
4 muscles.
Three muscles होते हैं.
जी हमजा, अगर you may tell, name the muscles of the thenar.
Adductor Pollicis, and the other one is Adductor Pollicis.
Okay. And Bakhtavar, you may tell the muscles of the thumb.
सर muscles of thumb में adductor pollicis भी include होगा बीच में. Adductor pollicis, abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis.
Correct.
4 muscles हो गए.
Correct. So you have to remember that in thenar and hypothenar, there are the three muscles which are corresponding to one another. But if we are specifically talking about the muscle of the thumb, there is a fourth additional muscle, that is the adductor pollicis, having two heads, oblique head and straight head. And these two heads are innervated by ulnar nerve, not the median nerve. So ये एक important चीज आपने याद रखनी है कि thumb के अगर if you are asked the muscles of the thumb, there are 4, and if you are talking about the thenar muscles, they are 3 in number. Then talking about the small intrinsic muscles of the hand, the moving superficial to deep, there are 4 lumbrical muscles which originates from the tendon of flexor digitorum profundus, and they move dorsally and are inserted to the extensor expansion of the dorsum of hand. So when these muscles would contract, it would lead to the extension of the digits and intercarpal joints. Is this concept clear? Okay, these muscles originate from the dorsal palmar side, but their distal insertion is on the dorsum of the hand and dorsal aspect of the digits. So when these muscles would contract, they extend the intercarpal joints. And why they are called lumbricals?
Because of the
they
resemblance
form
to
the L shape of hand.
Because they are spirally arranged, originating anteriorly and passing posteriorly. So that gives an appearance of a worm. ठीक है, एक spiral arrangement है, that is called the lumbricals. And they are in first and second is innervated by the branch from the median nerve, and the third and the fourth would be innervated by the branch from the ulnar nerve. So आपने एक और चीज याद रखनी है, the counting of these muscles start from the thumb side, lateral side. Start counting from the lateral side. Okay.
Sir.
जी.
Sir, lumbricals, palmar and dorsal interossei, इन सब का फंक्शन कॉमन है कि ये एक्सटेंशन करवाते हैं एट DIP एंड PIP, जबकि फ्लेक्शन करवाएंगे एट MCP जॉइंट. तो इन तीन काफी सारे अलग अलग मसल्स हैं, लेकिन फंक्शन एक ही है.
आपने बच्चे मेनली याद ये रखना है, फॉर lumbricals the function is, your action is extension of the digits at the intercarpal joints. For palmar interossei, they are the adductors of the fingers. They move them towards the midline, and the dorsal interossei will abduct. And the main function to remember is that lumbricals extends the digit at interphalangeal joints. The palmar interossei adducts the finger, and the dorsal interossei abduct. The rest of the function can be helped out by these muscles, with the main function that are specifically associated for lumbricals extension, palmar interossei, adductors of the fingers, and the dorsal interossei are the abductors of the fingers.
सर इंट्रोशे मसल्स 7 होते हैं या 8 होते हैं?
ये both the concepts are acceptable. In KLM there are 7, and in Snell or Grace they are 8. So both concepts would be acceptable. You need not to confuse. But the more preferably, if you say there are the 4 palmar and 4 dorsal interossei, that would be easy to remember and understand the functioning of these muscles. So preferably 4 palmar and 4 dorsal interossei to be mentioned. अच्छा, अब इसमें क्या नजर आ रहा है? What you see in this clinical condition?
Flexion of the interphalangeal joint of thumb.
And this is the testing of palmar interossei. Okay, that is the paper holding test. Normal. This side is the normal one, in which there is a proper grip, and this side the adduction is missing. So the grip to the paper during adduction of the fingers is not complete. Okay, we're seeing we in the 2 slides later. The same for ulnar nerve injury, the pinching movement is performed. The paper is pinched between the thumb and the little finger or index finger. Between the thumb and the index finger हम करेंगे. If there is no injury to the ulnar nerve, this gripping or pinching would be in the normal form, and that is similar to ये जो poster बना हुआ है, it is similar to what this is represents the OK sign. ठीक है. So from it sign is if this posture is not developed. When you compare these two, this is the normal posture when the index finger and the thumb finger are approximated. Okay, and that is called the OK sign. And here that is abnormal movement or at the joints, and that is called the abnormal, or the patient cannot perform the OK sign. And it gives this test is used to check the anterior interosseous nerve. From its sign is for anterior interosseous nerve. Paper grip test or paper holding test is for the branches of ulnar nerve or the palmar interossei. अब यहाँ पे हम देख लेते हैं. The palmar interossei adduct, ठीक है, and the dorsal interossei abduct the fingers. So to test these, paper grip test or paper holding test would be performed for the palmar interossei, and to check the dorsal interossei, the fingers are held by the examiner's hand, and the patient is asked to abduct. If the abduction is performed, the muscles are functioning normally, and if the abduction cannot be performed against resistance, so that would indicate the injury to the dorsal interossei.
सर ये एलन टेस्ट तो बता दें वो क्या होता है?
इसमें आपको क्या what you can identify in this condition? Zuhaib?
Yes sir.
What you can identify in this image?
इसमें सर ये
ulnar artery. It's okay.
Zuhaib, you may clear your concept and then I'll be clearing it to the whole class. Zuhaib.
अल्नर आर्टरी सर जी जा रही है, ये सप्लाई कर रही है फिंगर्स को.
नजर क्या आ रहा है? What you can identify, just let me know. Then I'll be clearing this.
ये ब्लड सप्लाई सर जी मीडियल 2.5 फिंगर्स की.
Okay. Allen's test is a clinical test that is used to perform the patency, to check the patency of the radial and ulnar artery forming the superficial and the deep palmar arches. To perform this, first thumb is flexed, fingers are flexed, and at the wrist joint radial and ulnar artery are pressed. So this would lead to the blockade of the blood moving or entering into the palm, and the palm would appear whitish. Then the arteries are checked one by one. First, when we release the lateral side or the radial artery, and the hand should become red, palm should become red within 2 to 3 seconds. So that would be clearing that the radial artery is, or the branches supplying the blood to the palm are functioning normally. You repeat the same procedure, holding at the rest. The palm would be again whitish in appearance, and now we would be releasing the ulnar side, and the palm should again become red within 2 or 3 seconds. This shows that both the arteries are functioning normally. If there is a delay in redness, redevelopment of redness of the palm, or the palm does not becomes red after 5 to 10 seconds, that would show the artery being stenosed, which is not supplying the blood properly. So this is the Allen's test. Zohaib, it is clear?
Yes sir, thank you.
Okay.
स्टेनोस का मतलब क्या होता है?
Narrowing.
Okay.
Can you, anyone of you, name the spaces which you have read in the palm?
Pulp spaces of finger, mid palmar space, thenar space, space of perona, dorsal subaponeurotic space, dorsal subcutaneous space.
Okay. So the mid-palmar space is lying under the Palmer Apinerosis, okay, and it is the synovial sheath which is covering the tendons of the flexor digitorum, superficialis and profundus. Along its lateral side, this area is the thenar space.
Sir?
जी.
Sir, Palmer Apinerosis फ्लेक्सर डिजिटोरम सुपर जो प्रोफंडस का टेंडन है उसके साथ साथ डिजिट्स टर्मिनल फेलिंग्स के साथ तक जाएगा कि सिर्फ ये पाम तक ही रहेगा?
It will remain up till palm.
जबकि डोर्सल एपोन्यूरोसिस टर्मिनल फेलिंग्स के डोर्सल साइड तक जा रहा है.
Because that expands to form the extensor expansion. Flexor side पे इस तरह की expansion नहीं बनती, so that is limited to the distal ends of the metacarpal bones or the metacarpophalangeal joints. The pulse space is for the distal phalanx region, and that is a confined space which does not communicate with any other area. Okay, so if there is any infection or accumulation of fluid in the pulp, that would be limited to this area, and the clinical condition is called the phalon or Whitlow. The mid-palmar space continues proximally with the space of perona. And what is the limit for the space of perona? In the forearm, it is present between, on the deeper side is the interosseous membrane and pronator quadratus deeper down, and superficially it is limited by the flexor digitorum profundus. So this is the space of perona. As flexor digitorum profundus originates both from the shaft of radius and ulna, so that would be an oblique origin limiting the space of perona, and space of perona interiorly communicates with the mid-palmar space. So यहाँ पे any infection of the mid-palmar space can extend into the space of perona, but the pulse space infection specifically remain limited to the pulps. What you can see in this diagram, redness and swelling of the pulse space, and this is called phalon or the Whitlow. Okay, if it is caused by the herpes simplex virus, so that type of Whitlow would be herpetic Whitlow. Herpes simplex virus se agar ho, so that would be herpetic Whitlow. Otherwise, phalon and the Whitlow are the same things. Achha ji. Now what you see in this diagram?
Sir?
जी.
सर एक बात इसी है कि थिनार स्पेस अगर अफेक्ट होगी तो पेरोना की तरफ इंफेक्शन लिमिट नहीं जा सकता. इसकी क्या वजह है जबकि मिड पामर की वजह से चला जाएगा?
Because of the direct communication with one another. ठीक है, कि space of perona is more towards the medial side and it is concerned with the tendons of the flexor digitorum profundus. ठीक है, so along its lateral side there is no communication with the thenar muscles. So that is the reason that the infection of the thenar space would be limited there, but the space of infection in the mid-palmar space can extend proximally into the space of perona. Mallet finger क्या होगा कि when the tendon of the extensor digitorum of the specific digits breaks at distal interphalangeal joint. So that would lead to the flexion, abnormal flexion of the distal phalanx, but the proximal and middle phalanx would remain intact. This is the mallet finger. और Mountainous deformity क्या होगी? और ये mallet's finger, what would lead to mallet's finger?
सर इस पे एक्सटेंशन खत्म हो जाएगी, फ्लेक्शन डोमिनेंट आ जाएगी.
फ्लेक्स पोस्चर में चला जाएगा, एक्सटेंशन एब्सेंट हो जाएगी. बट व्हाट वुड लीड टू दिस डैमेज ऑफ द मसल टेंडन?
Tearing of the extensor tendon.
Sudden forceful flexion of the distal interphalangeal joints in any condition can lead to the, again, there is a fall on the hand and there is this excessive force applied to the distal interphalangeal joint, so that would cause extensive flexion. And that it can be manually if the fingers are fully extended and suddenly that is flexed. That can lead to the breakage of the tendon. And this is the clinical condition. EKG showing the mallet finger. Now the Mountainous deformity is when the central slip of the extensor tendon breaks at the middle interphalangeal joint. So से क्या होगा? There would be extension of the distal interphalangeal joint and flexion at the proximal interphalangeal joint, mid interphalangeal joint, and extension at the distal interphalangeal joint. So this deformity would be showing the Mountainous deformity. That is the breakage of central slip of extensor tendon at middle interphalangeal joint. अब यहाँ पे आपको what you can identify among these four metacarpal bones. Anyone?
Fifth metacarpal का distal part.
Distal part. There is a fracture of this area, okay, of the fifth metacarpal bone, and it can involve the fourth metacarpal as well. Okay, and this fracture of the metacarpals can be in which professional or which condition?
सर बॉक्सर्स में होता है ये.
It is most commonly seen in the boxers, so that is named as boxers fracture, and that is defined as the fracture of the fourth and fifth or fifth metacarpal in the distal region because of the punching movement in boxing. Okay. Vincula longa and vincula breva are the
Folds of synovial sheath that connect
folds of
tendon.
synovial sheath, correct. And they perform two functions: holding of the trunk tendons or the slips with the phalanges, and secondly, they carry the small blood vessels for carrying nutrition to the tendons of the flexor digitorum profundus and superficialis, because tendons have less nutrition supply. So these small folds of connective tissue carry the blood vessels along with them to provide nutrition of these tendons in the distal portion. What is extensor expansion? What is extensor expansion?
extensor expansion is the continuation of the deep fascia at the dorsum of the hand that covers the metacarpus and the proximal part of the proximal fascia.
ठीक है, अब उसके अंदर दो तीन चीजें. The extensor expansion has the tendon of extensor digitorum location, then the extensor tendon of digiti minimi and the extensor indicis. Along with that, lumbricals are inserted to the extensor expansion. Okay. If we are talking about the carpal tunnel, what would be the important aspects? The questions asked can be: name the structures passing through the carpal tunnel, name the structures passing superficial to the flexor retinaculum. Okay. Then what is the arrangement of tendons of flexor digitorum superficialis while passing through the carpal tunnel? So you must recall that they are arranged in two layers, two tendons in the upper layer and two in the deeper layer. So the deeper layer would have the tendons for the ring finger and the middle finger, and superficially they will have the tendons of the index finger and the little finger. So you have to recall. So recall like this: the index and the little finger in the upper layer, and the middle finger and ring finger in the lower layer. So this is the arrangement of tendons in the of flexor digitorum superficialis while passing through the carpal tunnel. Radial bursa or mid-palmar space, what is the difference between the mid-palmar space and the radial bursa?
Mid-palmar space is a potential space consisting of only connective tissues, while the bursa consists of tendons and the synovial sheath.
Correct. So this synovial sheath covering the muscle tendons with the space having the synovial fluid are the radial and the ulnar bursa. And between these underlying muscles and this membrane, this is the radial bursa, mid-palmar space and the thenar space. So that differentiation should be remembered.
सर
जी
सर हम इन स्पेसेस को कह सकते हैं ये इंटरमस्कुलर स्पेसेस हैं?
Not intermuscular because they are present between the tendons of flexor digitorum profundus and superficialis in the medial side, and lateral side पे flexor pollicis longus के tendon and underlying muscle and connective tissue के दरमियान है. So that cannot be termed as intermuscular. Intermuscular होगा कि between the bellies of two muscles. Last चीज जो हम wind up करके इसको end करते हैं कि superficial palmar arch is the continuation of the ulnar artery in the medial aspect passing through the Guy's canal. The level would be at the tip of extended thumb. Superficial palmar arch lies at the tip of the extended thumb, and the deep palmar arch lies at the base of the extended thumb. ठीक है, formation superficial is direct continuation of ulnar artery and deep one is the direct continuation of the radial artery. इसने अब जो the branches which originate from the superficial palmar arch, one direct branch, first one that moves to the medial aspect of the little finger. Then there are three common digital branches that run in the region of the metacarpals, and when they approach the finger region or the digits, they bifurcate, supplying the adjacent side of little finger and ring finger and middle finger and index finger. Then for the thumb and lateral side of index finger, there are separate arteries which are the branches from the radial artery. For the thumb, the main artery is the princeps pollicis that will supply the lateral and medial aspects both, and radial side of index finger is supplied by the radialis indicis branch of radial artery. So if you have any queries or questions, let me know, and it's time for the next lecture.
Sir,
Ji.
sir, when you said that there are 4 muscles of thenar eminence, but 3 muscles of thenar compartment, can we say that there are 4 muscles of hypothenar eminence, but only 3 of the hypothenar compartment?
We have not said that, beta. We said that the thumb has 4 muscles and the thenar has 3 muscles.
Sir, but in KLM it is written that palmaris brevis is also a muscle of hypothenar eminence, but not of the hypothenar compartment.
That is the reason that palmaris brevis is a superficial muscle that originates from the flexor retinaculum and merges in the skin. So that is lying superficial to the palmar apinerosis. That is why that is not included in the thenar or the hypothenar compartment. That only gives a folding of the skin and does not perform any other function. So this is all for the review. Attendance is being automatically marked. Okay, and now you can attend the next lecture. Allah Hafiz.